Hello, everyone. I'm John Lynn, the founder and chief editor at Healthcare IT Today. And today we're going to really dive into a topic that's really important, which is e-prescribing of controlled substances. And we have an expert with us today. He's Cam Deemer, president of DrFirst. Welcome, Cam.
Hi, John. Thank you. It's good to talk to you today.
Yeah, so, before we dive into, e-prescribing of controlled substances, tell us a little bit about yourself and DrFirst.
Sure, I'd be happy to. So for the last 16 years, I've been president of DrFirst. If people don't know us, our company really creates technology platforms that are commonly used by EHR systems, hospitals, pharmacies, sometimes individual doctors, patients, and even payers. But it's all around electronic medication management and the workflows associated with that. We've tried really hard these last, really about 20 years, the company's been around, to focus on what we call the triangle of care, meaning the physician at the apex, the pharmacy and the hospital at the two other corners, and the patient in the middle. We started about 2 decades ago trying to work on those workflows around the triangle with e-prescribing and medication reconciliation. And then we gradually added some other complementary capabilities around like care team collaboration. We started making tools available to the patient that previously were only available to the provider community to support them in their decision making around their therapies. So basically trying to take a holistic approach to making sure that patients can both obtain and complete their therapies so we can get them to as good an outcome as we possibly can. Along the way to doing this, we've been involved in a number of pioneering approaches to e-prescribing, including developing the concepts behind the electronic prescribing of controlled substances, or EPCS. We'll probably just use that acronym today as we talk about it. We implemented the first pilot program under a waiver from the DEA back around 2010, and we're the first company to actually bring to market a commercial solution around this. Me personally, I got into HIT fairly late in my career. In the early 90s, I joined PCS Health Systems, which is it was a large PBM, prescription benefit manager at the time. It's all rolled up today under CVS Health. But way back then in the early 90s, we were just beginning the process of developing and promoting e-prescribing technology. And I think I was as surprised as anybody that it took so many years to finally make that technology, more of a standard of care. So that's us, and that's kind of how I got here.
Yeah, that's a great history, and it is amazing how much DrFirst has expanded. You even launched the telehealth, but that's really a discussion for another day. So, but it's great to have you here. Yeah, we'll have you back. So tell us, where are we at with e-prescribing today, and maybe controlled substances specifically? As you mentioned, it's been a long road.
Yeah, so as an industry, we're actually nearing saturation with e-prescribing, with the exception of a little dirty secret that I'll tell you in a minute. SureScript in their annual report noted last year that about 80% of providers across the country are enabled now for just generally prescribing. So that's pretty close to everybody. But they also noted that only about half were registered for EPCS, controlled substance prescribing. There seems to be a difference of opinion on this. The AMA just recently released a number of 20% of doctors being enabled for EPCS. So there's a pretty big gap between 20% and 50%. But the 50% number tracks pretty closely with what we see in our own user base. The dirty little secret around e-prescribing is we're about saturated with doctors, being registered to do it, but we're still seeing about 40% leakage out of the electronic workflows, meaning that even doctors who have EMRs, EHRs, the ability to write electronic scripts, about 40% of their time, they're still choosing to phone it in or fax it in or write it on a piece of paper. So, we're pretty heavily focused right now on how do we clean up that last 40%. But in terms of EPCS, a couple interesting notes. EPCS continues to, lag e-prescribing in general, in spite of the fact that many, many states now have mandatory EPCS regulations. You're required by the state to write controlled drugs electronically. Interestingly, the regulations had an unexpected side effect. The process of registration and the workflows involved in EPCS were perceived as so onerous by doctors that they just stopped writing pain meds rather than, adopt the technology, which created an unexpected crisis in pain management as patients found it harder and harder to find a doctor who was actually willing to write a controlled substance for them. But one thing that seemed to help, oddly enough, was the recent pandemic. Practices, you mentioned telehealth earlier, practices have quickly turned to telehealth and remote visits, and maybe because they're already trying new things, we've seen a strong uptick in interest in EPCS as well. So it's kind of been a small silver lining around this otherwise, big healthcare problem we're all dealing with. There is something coming down the road, January 1 of next year, 2021. There is a federal regulation that will require EPCS for Medicare controlled substance prescriptions. So we do expect that will it'll probably encourage a lot more EPCS registration, but also may just exacerbate that pain management crisis that was an unfortunate side effect of this.
I was going to say, I think that will happen the same with Medicare, and maybe more. I mean, there's whole organizations opting out of Medicare completely. So to opt out of EPCS might be that, might cause even more issues. But it's really interesting at the macro level, especially the dirty little secret, 40% not doing it. Although my guess is that telehealth has helped that problem a little bit as well. If you can't see the patient to hand them a paper script, you maybe look at other options.
What's driving that, I think, John, is what I would call two myths about e-prescribing. One myth is that if you're using an EHR, you consider yourself an e-prescriber. So, I mean, that makes sense, right? So do you e-prescribe? Absolutely, I e-prescribe. Do you e-prescribe everything? Absolutely, I do. But yet we find 40% of the time they don't. So, just the possession of an e-prescribing system seems to make people believe that they're fully in line with, e-prescribing, when in fact a large number of scripts, either because, they may be too busy and it's just faster to write it on a piece of paper than get into the whole EMR workflow, or maybe they're on call and they're doing all the scripts, on the phone instead of, taking the time to VPN in and authenticate into their system. Whatever the reason is, a lot of people say they're doing e-prescribing, but they're only doing it 60% of the time. The other myth is that it's not okay to use a second system. If I'm using a major EHR as my primary system, and when I'm not in the office, it's too much trouble to VPN into it, there's no reason in the world I can't use, an application like DrFirst EPrescribe on a phone, and use that instead of, calling the script in, which helps the pharmacy a lot because they're all set up now for electronic workflows, not taking phone calls. And it gives the patient all the same protections e-prescribing does, gives the physician all the information regular e-prescribing does, and it'll flow back into the EMR later whenever they pull a med history on the patient. They'll get back the drugs they've prescribed for that patient. So there's no problem at all with using more than one system. There's only a perceived problem that's not okay.
Yeah. I think the perception of I'm an e-prescriber reminds me of so many scenarios, even with wellness visits or even breast cancer screening, different things like that. They're like, oh, I ask every single patient that. And then you run the report and you're like, there's a difference between perception and reality.
Yeah.
And then when you see the data, you're like, oh yeah, that patient I didn't because of this, and that one I didn't. You're like, okay, now we're down to the core issue.
Our minds are funny things, the way they work.
Definitely. So let's talk about, the DEA really established this back in about 2010 timeframe, and it kind of reminds me of HIPAA. And you correct me if I'm wrong, but I haven't seen any major changes to the legislation since 2010. I think HIPAA's been somewhat similar. They've had one or two you might call major changes, but it's the same with e-prescribing of controlled substances. They put out the policy in 2010, and there's been, I think, some minor tweaks or whatnot, but nothing major. So how has that, really those policies that were established a decade ago, which the iPhone came out just before that, like how has that held back, EPCS?
Yeah, so we're going to be talking today, I believe, about how some of the regulations really need to change. But I think it's only fair to recognize that, getting any regulations around EPCS was a huge task. I mean, there was, between the early 90s and 2010, a lot of years went by with no ability to e-prescribe controlled substances at all. So kudos to the DEA for making it happen, when they did 10 years ago. EPCS differs from standard e-prescribing in that this is why it was hard to get those regs. It's not just about ordering a drug therapy. With EPCS, there are also legal and criminal issues around these tightly controlled drugs. So diversion is a continual concern, fraud. The DEA, plays the key role in managing the criminal side of this. So when the regulations were initially conceived, there was a lot of focus on non-repudiation of identity. In other words, if it looks like you wrote the script, you're not going to be able to say, oh, that wasn't me. My nurse has my password, so she wrote that script. Don't come after me for drug diversion. The idea was that bad actors needed to be effectively prosecuted, and that was the real focus of the regs. There was much less focus on clinical efficiency, or what the experience would be like for doctors. So with many years of practical industry experience under our belts now, we think it's time to think, harder about how to improve the clinical experience for the docs, while still maintaining this legal foundation that lets the DEA do what it needs to do in the process. Today, it continues to be really difficult, for instance, to get doctors through the identity proofing process required by the DEA. The traditional process involves requiring the physician to answer a number of very personal financial questions. And the questions are so obscure that doctors quite often fail the first time through. In fact, through our experience, it's not uncommon for more than half the doctors to fail the first time through. They also have to lift credit locks temporarily to allow access to their information. They have to come to grips with why their financial lives, which they consider very private, are being dragged into this EPCS registration process to prove who they are. And that was all just very difficult to get doctors to come to grips with. There are newer methods of doing this that don't require so much focus on their finances, but typically any of the standard identity proofing workflows that meet DEA requirements are quite confusing to prescribers because they use unfamiliar terms and workflows that don't necessarily make sense. So that's one of the things that's been a real problem in not updating the regs, is just getting you identity proofed is a giant hassle. The second piece is two-factor authentication. The acceptable two-factor authentication technology was greatly constrained by the original regulations, and between the identity proofing and the two-factor authentication, innovation's been very constrained in this space because technology's changed a lot in 10 years, but the regulations have not changed.
Right. So, I think it is interesting. You put out a, I don't know, press release, blog post, probably all of these things above, right?
Yeah,
Kind of
probably.
pushing for the changes, right, and suggestions on how the DEA could improve it. And I'm glad that you talked about it. It is a balance, right, between the criminal side, the security side, the usability, all of these things. And we have this discussion a lot. Security and usability are often at a head, right, depending
Right.
on how you do it. So, it's interesting. You already you proposed 5 changes. You talked about the one, right, which is clarifying identity proofing requirements and doing that.
Mm-hmm.
The other one you just mentioned was the two-factor authentication. And it's interesting, you brought up 2 points on that, which I think are super interesting because it's the complaint I hear the most about, which is, oh, why do I have to do two-factor authentication? And that's a discouraging factor for why they aren't doing e-prescribing of controlled substances. So you said in one of them allow two authentication factors on one device. I guess the question I have there is, doesn't this make this 2 factors less secure if it's on the same device? Like, isn't there a security implication if it's all on the same device? And what's the point if the device is compromised? What's your take on that?
Yeah, so let me lay a little groundwork for this one, John. In order to answer that question, let me talk
Sure.
a little bit about how the current guidelines have not kept up with technology in this space, and then I'll explain how that applies to the single device. You mentioned before, we were just talking about the standards are a decade old, so of course things have changed. One area where the current regs lag quite a bit is tokens. Tokens for two-factor authentication are required to meet the standard defined in a document called FIPS 140-2. I'll say FIPS several times while we're talking. It stands for Federal Information Processing Standard, and it really defines requirements for the technologies need to meet in order to satisfy like government procurement requirements and things like that. They aren't really medically related per se. They've been adopted. They were originally intended for a different purpose, and they've been adopted into this clinical workspace. So you can imagine they don't consider anything in particular about how a doctor will have to work.
Sure.
So in the years since those requirements were written, other standards have become much more prominent in the general security community. For instance, the FIDO Alliance allows much simpler processes for applying tokens in workflow. By applying tokens, I'm talking about like the one-time password or the security certificate that you need to transfer from the token to the EPCS system. So generally today, EPCS uses a one-time password that you enter off of a hard token into whatever EPCS system you're using, whether it's on a desktop or on a phone. There are some alternatives, but the hard token is the most prominent today. You've probably used one of these before, like when you worked for a company and they had a VPN and you had to like pull that out of your pocket, look at the number on it,
Yep.
type it into your system, and then you're good to go. That's fine for logging into a system when you start your day, but imagine if every time a patient comes through your office, you write them a prescription, and now you got to pull this thing out of your pocket, look at it, type it into your system. That gets pretty old after the first 5 or 6 times a day, and doctors often have to do it many more times than that. So the technologies promoted by, for instance, the FIDO Alliance, eliminate the need to manually enter that one-time password. It's called an OTP. An example of that is a token called YubiKey, which uses NFC or near field communication, and it lets you just tap the token on your computer or just get it close to the computer or your phone, and
Yep.
it'll pick up that one-time password automatically. There's also Bluetooth options, so you might be able to just leave it in your pocket and not even take it out. And there's a lot of vendors to choose from. With the old style hard tokens, the number of vendors available is quite small. with the new FIDO Alliance, adherent tokens, there's a lot of innovation, a lot of vendors doing interesting things. So they give you the opportunity to maintain security and do good workflow at the same time. And streamlining physician workflow is really a key to getting, EPCS not just adopted, but widely used. So then that brings me around to your question about two factors on the same device, and isn't that less secure? And my answer is going to be no, it actually isn't less secure, although I completely understand why it sounds like it is and why it would seem to be that way. So let me just kind of quickly walk through it. Currently, the DEA requires a prescriber to authenticate into his EPCS system using at least 2 out of 3 possible elements. So the elements are something the provider knows, which could be a password that only they know, something the provider has, which could be a hard token or a phone, something the provider is, which would be biometrics, like your fingerprint, your iris pattern, shape of your face, whatever. Over the last 10 years, technology has developed to the point that a separate hard token isn't the only way to ensure compliance with FIPS 140-2. Today, Apple phones, Google phones, they've got operating systems that have undergone FIPS 140-2 validation. So they have the proper security built into the phone itself to meet the security requirements. The authentication apps on the phones also are FIPS 140-2 validated. And it's very straightforward now to ensure that through, kind of a combination of modern biometrics, which is something you are, and passwords, which is something you know, on a smartphone, which is something you have, gives you an appropriate level of authentication and non-repudiation, even though it's all on the same device. I mean, we can be much more sure that you're you than we would be if somebody stole your one-time password off your keychain, and then used it instead of you.
Yep.
So as it stands today, this requirement for a separate token really is just creating one more barrier to adoption because of the way it disrupts workflow.
Well, and it is amazing how those devices have finally embraced the biometrics, whether it's facial or fingerprint or whatever it might be. I think, I actually started doing that 15 years ago with a facial recognition solution, which I loved on my computer. It literally would log me in. But at the time, everyone thought it was magic, and now they do it every single day on their iPhone, right? So
yeah, that's right.
It's amazing how our perceptions have changed.
Is that a problem if you've got a quarantine beard? Does your computer forget who you are?
Well, it turns out beards are fine because it actually learns your beard as it grows because it continually updates the biometric recognition. But turns out it works with pregnant women as well. Their finger, they'd say a handprint, that does the same thing because when you're pregnant, you blow it. Anyway, not to go too much into biometrics. Exactly, but because it changes a little bit at a time, it adapts with you and knows you as you adapt. And although maybe my quarantine one is the extra 15 pounds, but that's a different. My COVID-19, as they call it, right?
Just gain it slowly, John. Gain it slowly.
Well, that's more of a value-based care issue, but no, that's really interesting. And is that some of the alternatives? Because you also suggested that we should have some alternatives to two-factor authentication. Is it really the Wi-Fi or Bluetooth enabled, or what were there other solutions, or were those the ones you're really talking about?
So what we were questioning in the letter with our recommendations to the DEA was when you look at things like modern biometrics, you start to question whether two-factor authentication is even needed anymore. Previously biometrics were too expensive because special devices were needed to meet the requirements. But it's different now. There's a NIST document, it's special publication 800-76-1. It outlines the false match rate that you must meet with biometrics to be acceptable for security for, prescribing controlled substances. Today's commercially available biometric systems actually exceed that false match rate by quite a bit, but they don't necessarily meet all the other requirements in that NIST document, because NIST was, again, speaking to government applications and not the commercial e-prescribing space. So we'd like to ask the DEA, to take a step back, recognize the progress made in the security industry generally, and allow the use of more modern biometrics, ideally allowing single-factor authentication instead of two-factor authentication, and probably creating even greater security as a result of doing that. I did want to mention, though, some other approaches. You asked about, other ideas. One of the things we think is very promising is the use of machine learning and AI to monitor user interactions with a screen or with a device to determine whether the way you're using it is consistent with who you are. This is a lot like your facial recognition thing, right? It learns you over time, keeps up with any slight changes, but actually is doing a pretty good job of identifying that you're the person you say you are. For anybody who's familiar with CAPTCHA, that really annoying thing you have to do to prove you're not a robot when you're on a website. You remember the really old CAPTCHAs where they just had the kind of outrageous fonts with numbers and letters, and you had to like read it and type it in because robots weren't so good at that. And then later they graduated to picture identification, and they're like, pick out all the pictures that have a crosswalk in it.
Yep.
And if you screw up, then it says, okay, now do it again because we're still not sure you're not a robot. And eventually, hopefully you get it right. They've actually moved on now to their maybe third generation. I don't know how they count, but I would say their third generation, which is where they're actually observing what happens on the screen, looking at mouse movements, things like that, to determine whether it's a human pattern or a robot pattern. So we could apply those same kind of concepts to e-prescribing. I mean, you have the physician's prescribing habits, the times they work, how much time it takes them to enter information, how they interact with the screen, in terms of like pressure and speed, many other factors that can go into this. And it's possible that a person wouldn't need to do much of anything at all other than just let the computer monitor who they say they are. So those kind of approaches, we're just asking the DEA to take a look at whether technology hasn't progressed to the point that some of those are feasible now.
Yeah, I've seen it even with typing speed or typing style, how do you do it? I would even extend it, some of these ambient clinical voice or virtual AI assistants that are becoming more popular. Like you can imagine if I've already told the AI assistant that was listening to me and documenting the visit, they could authenticate my voice, they could authenticate my pattern, my speech, everything. So that would actually be, I think another extension of what you're talking about using the new technology.
I think a best case scenario would be if, in its wisdom, the DEA could work out a way to generalize the requirement enough that it does leave room for the development of additional technologies. Like if voice isn't quite good enough now, maybe voice will be good enough next year, right? So leaving room for innovation is just really important in this next round of rules.
Yeah, it's a great point. But if an AI assistant's been listening to me for the last 15 minutes and can't identify me, something is wrong, right? Like that you would think.
The only way I can really be sure is to wait for the next Mission Impossible movie and see what Tom Cruise has up his sleeve.
That's so funny. I've been showing my kids some of the old ones to give them a flavor for what it used to be, and they're like, "Oh, that's real." That's good. So, you had a couple more. Let's run through those quick to finish this out, just to be comprehensive. But you suggested incorporating current industry guidelines and standards. I think we've talked about some of them. Are there other guidelines and standards from, I think NIST has put out a bunch that are really interesting as well. But, are there others that you think the DEA should consider and they haven't?
One of the things that we think is important actually is to take a look at the way identity proofing is handled. We actually don't quibble with the DEA that identity proofing is extremely important.
Sure.
So we don't, in a sense, we don't disagree with the requirement that it be handled very carefully. What we did raise with the DEA was that we know they are considering a revision to how identity is documented. This is probably going to be the most obscure thing we talk about today, John, but I'm just going to kind of power through it here. There is a NIST publication, 800-63, revision 1, which specified how to document identity proofing to get a prescriber to what they called LOA 3, level of assurance 3. And that was the level considered suitable to meet the DEA's requirements for non-repudiation of identity. Currently, NIST is on, that was revision 1. Currently, NIST is on revision 3 of that document, and they're in process on revision 4. They have changed the concept of level of assurance to something they call identity assurance level, which sounds virtually the same, but it's actually enumerated differently and has some higher requirements for documentation. But it's now called IAL2 is the level you've got to be authenticated to. So it's a higher degree of identity proofing, but it also allows a wider range of documentation choices. We think it's really important as the DEA is moving up to this standard to be very clear which sources of documentation are acceptable, so we're not left wondering if we still have to use the old documentation choices or it's okay to adopt new documentation choices. So we'd like to have that clarified. But even more importantly, the DEA, if a doctor's already gone through identity proofing, the DEA should not require the physician to go through it again. They should grandfather the method as long as, you know, they're basically using the same vendor software they were identity proofed with previously. This gives us at least some level of portability of the physician's identity, and also doesn't frustrate them that, hey, look, I already got LOA 3, why do I now have to redo everything to get IAL 2? So we would like some, you know, some grandfathering of that. Other than that, you know, we talked earlier about the biometrics issues. We're just looking for, rather than strictly adhering to standards which were targeted to federal security protocols, that we'd really like the DEA to recognize what the commercial security sector has been up to and how strong these systems are now to give us a really good feel for someone's identity.
No, and I think that is an interesting, you know, that was the last one really, is updating those requirements for biometrics. I think the government does have a different standard than healthcare, and, you know, and the different usability principles. So I think it makes sense for them to evaluate what is the commercial industry doing, not sacrificing security, which is still important, but at least updating the options. I think your point about the cost of biometrics being so much less now, since you don't need a dedicated device, you probably have the device, is another good explanation. So are these changes that we've talked about, are they things that the DEA has discretion over and they can make those changes, or does it require legislation to make them?
Yeah, that was actually a really good point, John, because these things just absolutely take forever if legislation is required.
And maybe never.
Especially in our current gridlock, right, where we can't seem to make any decisions. The good news is, yeah. The good news is, like other federal agencies, yeah, the DEA does have the authority to implement rules for EPCS. I'm sure you're quite familiar with this. There's a rulemaking process,
right?
And it gives industry stakeholders like DrFirst and other companies, as well as just the general public, an opportunity to comment on any proposed rules and to submit feedback before the changes are finalized. So this should be able to proceed without additional legislation. And again, we wish the DEA the best. It's hard to please everybody, but I hope they'll just think hard about how to, you know, really make this efficient for the doctor, so the doctor doesn't become frustrated in serving, you know, the real needs of the patient. We don't need to create an environment in which it's even harder to receive needed care. We just really need to make room for clinicians to be able to do their work.
Yeah. Well, and it seems like now is a good time to do that, as most of them are going to be doing all sorts of virtual care and other things where, you know, making it as virtual as possible and as easy as possible, especially with all the doctors overwhelmed with dealing with COVID-19 patients, influxes, weird schedules, everything else that's burning them out. They don't need one more thing as far as finding their token, etc. Right?
Yeah, that's right.
Doing them down. So thanks so much for sharing all these insights, Cam, and I appreciate you pushing it forward. And you know, hopefully we can help the DEA to. I mean, it's a hard process, as you mentioned, but hopefully this will offer them some ideas on how to continue to improve it. And thanks everyone for watching. We've been here with Cam Deemer. He's president of DrFirst. And if you want to find more great healthcare IT content like this, check it out at healthcareittoday.com. Thanks, Cam.
Thank you, John.